Thank you all so much for joining us today. We are here for the evidence-based palliative symptom assessment and management of nausea and vomiting. This is a recap of something we covered off a couple of years ago, and today we are going to take a recap of the video from that recording, and then we are going to go through some case studies with our presenters for today. And I'd like to go forward with our land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council comprised of the Chippewas of Beausoleil, Rama, and Georgina First Island Nations, and most recently, the Mississauga of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. And we are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in a spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And we are here for the Palliative Care Echo Project, as you are all aware. This is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illnesses. For more information, you can go to echopalliative.com. And we would like to extend a thank you to Health Canada for their financial contributions to the Palliative Care Echo Project. Without your assistance, we would not be able to do what we're doing today. Thank you. Now, I'd like to do some introductions. For those of you who this is your first time with us today, my name is Amanda Tavelda, and I am the Communications, Fundraising, and Community Relations Specialist with Hospice Aurelia. Our presenters today are Laura Bates and Linda Meeks, both with the North Simcoe Muskoka Hospice Palliative Care Network. Ladies, the floor is all yours.
Excellent palliative symptom assessment and ongoing management are based on the acuity, complexity, and variability of the person's condition. The use of standardized and evidence-based tools promote this excellence in practice. Nausea and vomiting are common and distressing symptoms in palliative care, affecting the majority of patients with cancer and other life-limiting illnesses. A systemic review of the prevalence of common symptoms in patients with varying life-limiting illnesses found that pain, breathlessness, and nausea and vomiting appear to be more common as death approaches. In patients admitted to specialist palliative care programs, nausea was reported by 36% of the patients at first contact with the service, 62% at 1 to 2 months before death, and 71% in the final week of life. In patients receiving palliative care, nausea and vomiting rarely occurs in isolation. They tend to cluster with other symptoms like fatigue, drowsiness, decreased appetite, and dyspnea. So for today, by the end of the session, participants will be able to explain the emetic pathway, discuss the etiologies of nausea and vomiting, review the clinical assessment and tools used, and identify the non-pharmacological and pharmacological treatments of nausea and vomiting. Clarification of the definitions of nausea, vomiting, and related phenomena is important for the correct assessment and treatment of these symptoms in patients receiving palliative care. Nausea is an entirely subjective experience defined as the sensation that immediately precedes vomiting. Patients state that they feel that they are about to vomit or describe the sensation as being queasy or sick to their stomach. Retching is the repetitive active contraction of the abdominal musculature generating the pressure gradient, which leads to the evacuation of the stomach contents. Retching may occur in isolation without the discharge of stomach contents, and this is referred to as the dry heaves. Vomiting is described as the actual ejection of stomach contents and is the result of contraction of the gut and thoracoabdominal wall musculature. Regurgitation is the passive retrograde flow of esophageal contents into the mouth. Good evidence exists that various stimuli that affect nausea and vomiting come together in the area in the brain known as the vomiting or emetic center in the medulla. This center is not a discrete nucleus, but a complex array of neurons coordinated by a central pattern generator. Still, for our purpose today, it is useful to think of the final pathway that gives rise to the vomiting emetic pathway. So I'd just like to explain this to you so that we can continue on and realize the understanding of the emetic pathway for assessment and treatment. The vomit center receives input from 4 major areas: the GI tract, the chemoreceptor trigger zone, the vestibular apparatus, and the cerebral cortex. The center also has intrinsic chemoreceptors that can modulate, stimulate, and repress nausea. Each of these 4 areas responds to certain types of stimuli, modulated by specific neurotransmitters that bond to specific receptors. Understanding how these areas modulate nausea and vomiting helps us to tailor specific therapies for specific problems. As a primary source of toxic absorption in the gut, the effect of the GI tract on the vomit center is complex. Stimulation of the gut receptors and stretch receptors triggers nausea and vomiting via the vagal nerve afferents and afferent fibers associated with the sympathetic nervous system. The chemoreceptor trigger zone, or the CTZ, senses chemicals in the blood. The CTZ is particularly sensitive to increasing blood levels of potentially toxic substances. If a toxic substance is detected, nausea is experienced and the vomit reflex is initiated, hopefully before more toxic is absorbed. The brain detects an alien chemical, and if the concentration of the chemical is rapidly rising, this could constitute a threat to our health. So better to expel any residual substance in the stomach. Motion and body position are sensed through the vestibular apparatus. Motion sickness, such as car sickness, are mediated through this apparatus, as are inner ear diseases such as Meniere's disease. The vestibular apparatus serves as a sensor for certain toxins, such as alcohol, that can produce disequilibrium. Stimulation of the vestibular apparatus by alcohol may provide a survival advantage in keeping us from literally drinking ourselves to death. The cerebral cortex and associated structures in the limbic system modulate complex experiences such as taste, sight, and smell, as well as memory. And this is the mechanism that's involved in anticipatory nausea and emotion. Discrete neural pathways are less well understood. Receptors and neurotransmitters act like a lock and key system. Just as it takes the right key to open a certain lock, a neurotransmitter, which we will call the key, will only bind to a specific receptor site. Neurotransmitter receptors transmit the actions of the bound neurotransmitters, thus enabling cell-to-cell communication in the nervous system. Serotonin, acetylcholine, histamine, and substance P are major neurotransmitters in the gut. Chemoreceptors in the gut are major mediators of the toxic effect of certain chemotherapeutic agents, such as cisplatin, even when drugs are given intravenously via binding to 5-HT3 receptors. In addition to being a neurotransmitter that stimulates nausea, acetylcholine also increases gut motility and gut secretion. Histamine mediates transmission of nausea via the vagus nerve. Substance P binds neurokinin 1 receptors in the gut and directly into the vomit center in the brain. Two major transmitters are involved in the chemoreceptor trigger zone. Dopamine acting on D2 receptors and serotonin acting on 5-HT3 receptors. Different toxin responses are mediated through different neurotransmitters. Opioid-related nausea appears to be most related to the stimulation of D2 receptors. Stimulus of the vestibular apparatus is mediated largely through histamine and acetylcholine receptors. Higher cortisol effects are important in the cerebral cortex and can be extremely powerful in stimulating nausea and vomiting. GABA is a neurotransmitter that blocks impulses between nerve cell in the cerebral cortex, and low levels may be linked to anxiety. Cannabinoid receptors are involved in a variety of processes, including appetite, pain sensation, mood, and memory. Common syndromes are involved with nausea and vomiting. Biochemical organ failure, chemotherapy, and drug-induced nausea and vomiting can result from fluid and electrolyte imbalances, organ failure, chemotherapy, and medication side effects. Gastric stasis, induced nausea and vomiting, can be a result of carcinoma of the stomach, ascites, opioid and anticholinergic drug side effects, and peptic ulcers. Gastrointestinal obstruction or irritation-related nausea and vomiting can be related to cancer, esophagitis, peptic ulcer, gastric distension and compression, delayed gastric emptying, bowel obstruction, constipation, biliary obstruction, peritoneal disease, adhesions, chemotherapy and radiation, and infection and medications. Increased intracranial pressure that results in nausea and vomiting can be a result of cerebral edema, intracranial tumor or bleeding, and meningeal disease. Vestibular disturbances that trigger nausea and vomiting could be opioid-induced or due to cerebral metastases or motion sickness. Psychological induced nausea and vomiting may be due to fear, anxiety, and the anticipation of certain events.
Thanks, Linda. As you can see, nausea and vomiting is quite complex, and there isn't always a clear-cut answer as to why it is happening and what's going on. But now that we have a better understanding of the emetic pathway and the etiologies of nausea and vomiting, it will allow us to better assess nausea and vomiting. The assessment of nausea and vomiting is based on the understanding of the emetic pathway and the neurotransmitters involved, because the majority of antiemetic drugs are predominantly neurotransmitter blocking agents. They work at the receptor sites to block the receptors and prevent the message of nausea and vomiting to reach the brain or to go from the brain back into the body. Careful assessment will lead to a rational selection of an antiemetic agent to try. The first thing to do when you remember about assessing a symptom is to do so in the context of your patient's goals and values while taking their current PPS or palliative performance scale score into account. In order to do this, you need to know some other information about the patient's medical condition. This includes knowing their diagnosis and prognosis, any comorbidities that they may have, whether there is known or suspected metastasized disease, their current and previous medical treatment, such as chemotherapy, radiation, or surgery. And it is also important to know current medications, herbal supplements, over-the-counter medications, and vitamins. Finally, a thorough assessment of the physical systems, preferably done after the nausea has started so that it is recent, is important so that you know what the patient's change in baseline status is. Because nausea and vomiting are complex and can have multiple etiologies, a thorough history and physical is required to ensure that all possible causes of the nausea and vomiting are identified. There are a multitude of tools used to assess nausea and vomiting. In order to do it thoroughly, you must both quantify and qualify the characteristics of the symptom and its effect on your patient or client. Each of these tools listed on the slide can be used separately, but on their own do not provide a holistic view of the symptom and its effects on your patient. The Cancer Care Ontario symptom management algorithm combines all of these tools into one tool to guide your assessment and management of the nausea and vomiting. This is the first page of the Cancer Care algorithm, and as you can see, it is a step-by-step process that allows the practitioner to complete that comprehensive assessment that's required. The first step is to complete an ESAS, then assess the nausea and vomiting using the adapted assessment acronym, complete any further additional assessments, and then determine whether the patient or client is experiencing mild, moderate, or severe nausea. And we'll go into each of these steps in more detail next. Many who work in palliative care are familiar with the ESAS. It is a thorough and multifaceted assessment that allows you to look at the symptom profiles when you collect it over time. Typically, the client will complete the ESAS independently, but if not, the patient or client can be assisted by a caregiver or a healthcare professional in order to complete it. Each symptom is rated on a scale of 0 to 10 to measure the intensity of the symptom. It is a validated tool for both self and proxy reporting. It has also been translated into a multitude of languages, and there is a transcultural adaptation to be used in low and middle income countries. By assessing all symptoms and not just nausea and vomiting, the healthcare practitioner is better able to see if there's a correlation between the nausea and vomiting and any other symptoms that may be arising. The adapted assessment acronym is typically used when assessing pain. However, it does have a role in assessing other symptoms, including nausea and vomiting. It allows the practitioner to determine the meaning and impact of the nausea and vomiting on their patient and gives qualities of the symptom. So we'll go through each of these individually. Onset, when did the nausea begin? When did the vomiting begin, if there are both? If the patient is currently undergoing active treatment of any type, this will also allow you to determine whether it is acute emesis, delayed emesis, chronic emesis, or anticipatory. Acute emesis occurs within the first 24 hours of the treatment. Delayed emesis occurs in 24 to 48 hours after the treatment. Chronic lasts for more than 48 hours after treatment, and anticipatory happens before treatment in the anticipation of the treatment happening. Think when someone has treatment, they become nauseous, they vomit, they're anticipating their second treatment, and they may become nauseous before that treatment because they are assuming and guessing that they will become nauseous afterwards. Provoking and palliating. What brings on the nausea and or vomiting? Is it associated with a specific activity or the onset of a different symptom? What makes it worse? What makes it better? Quality. Can the patient describe how it feels? Is there nausea with or without vomiting? Is there vomiting without nausea beforehand? Is the nausea constant or intermittent? The severity comes back from our ESAS, where we've rated it on a scale of 0 to 10. ESAS, to be noted, is at this current moment, not in the past or an average. However, you can ask your patient, has the nausea been worse or better? What is its rating when it's at its worst and at its best? You can put this into the context of a specific time period, for example, the past week or since the symptoms began. Treatment. Are they using any medications or treatments to try and alleviate the nausea already? How are they using them? Are they using them around the clock or as needed? How effective are they? Are there any additional side effects from the treatments or medications that they're using for the nausea? Are they using any non-prescribed medications, such as over-the-counter medications or herbal and alternative medications to try and deal with their nausea and vomiting? Understanding is looking at what the impact is on the patient or client. Do they have any ideas about what they believe is causing the symptom? How is it affecting them and or their family or caregivers? Is their appetite or the amount that they are able to take in affected by the nausea and vomiting? And if so, how much and what are they able to eat or drink? What can they tolerate? What can't they tolerate? Are there specific types of foods or fluids that they can or cannot tolerate? Values looks at any other additional worries or concerns about the symptom that the patient and or their family may have. There's some other questions and assessments that need to be done in order to fully understand the possible causes of nausea and vomiting. In addition, these other important pieces of information are required to get the whole picture and determine, again, those possible causes. In addition to the previous background information and what you've learned through your assessment thus far, you should also think of and investigate the following. You want to know the date of your patient's last bowel movement, what its consistency was, and whether there have been changes in the pattern before or after the nausea or vomiting have started. You want to inquire about their weight before the start of the nausea and vomiting and whether there has been any weight loss because of it. If their oral intake of food or fluids has been affected by the nausea and vomiting, then you should complete a screening for malnutrition, and there's 2 listed there on your screen, which are also listed in the Cancer Care Ontario algorithm. You should complete a full physical assessment consisting of vital signs, an assessment of the oropharynx and mucous membranes, assess their hydration status, looking for signs of decreased urine output, dry mouth, or additional issues that may indicate dehydration, an assessment of the abdomen, and a rectal assessment to determine whether there possibly is fecal impaction. A neurological exam should be performed to rule out increased intracranial pressure or any other neurological etiologies, especially when nausea and vomiting is accompanied by headache. In the presence of moderate or severe nausea or vomiting, if there are signs and symptoms of dehydration or malnutrition, then additional blood work should be completed to assess blood count, electrolytes, urea, creatinine, glucose, and calcium. If a change in disease status is suspected, such as a change in the tumor load or new possible abdominal metastases, fecal impaction, or bowel obstruction, then consider X-rays and CT scans if clinically indicated and if they are within the patient's goals and values. If a patient is experiencing vomiting, then you need to assess the quality, frequency, quantity, and color of the emesis. Some other questions to think about while assessing your patient in order to help you think of potential causes of nausea and vomiting are these. Some of these causes would be considered palliative emergencies and warrant immediate investigation and treatment, again, in the context of the patient or client's wishes and goals of care. You want to know whether there's any additional symptoms such as anxiety or pain. Are they diabetic or newly diabetic and having a change in their blood sugar control? Is there signs and symptoms of a bowel obstruction or a GI bleed? Are there symptoms of increased intracranial pressure? Possibly symptoms of new or worsening infection? And are there signs and symptoms of new or worsening renal or hepatic dysfunction? These are all important things to keep in the back of your head as you're assessing your patient. So the Cancer Care Ontario algorithm classifies the severity of nausea into 3 categories: mild, moderate, and severe. Each classification is based on the rating of the symptom on the ESAS and some additional information. Mild nausea is rated as 1 to 3 out of 10. There may be loss of appetite, but there's no alteration in the eating habits and no dehydration. This would include people who are having anticipatory nausea. Moderate nausea is rated at 4 to 6 out of 10. There is decreased oral intake, but without significant weight loss, dehydration, or malnutrition. If they're receiving active treatment, they may not be able to eat or drink within 24 hours of that treatment. If their oral intake has been unchanged, there still may be evidence of dehydration for someone with moderate nausea. It is also classified as moderate nausea if a change in their treatment is not effective within 6 hours. Severe nausea is rated to a 7 to 10 out of 10. There is inadequate oral caloric or fluid intake and signs that may warrant possible hospitalization and further investigation. These signs would be evidence of dehydration or electrolyte imbalance if there is blood or coffee ground emesis or severe abdominal pain or headache. If a patient is weak, dizzy, incoherent, unresponsive, or showing other cognitive changes, that would also classify as a palliative emergency. There is extensive anecdotal evidence and scientific studies to support the use of non-pharmacological treatments for nausea. The first step in treating nausea and vomiting is to ensure that there is adequate control over all other symptoms and that there's treatment of any underlying causes that can be reversed. Every family and every person has their own tricks and tips on how to deal with nausea and vomiting. And some people may find that the use of relaxation techniques and complementary therapies such as aromatherapy or acupuncture are helpful. There's lots of other small tricks and tips that can be helpful. These include remaining upright or semi-reclined while eating and drinking and for a period of time afterwards, or something as simple as a light walk after a meal to help improve digestion. Some people find that altering their diet helps to alleviate their nausea by avoiding their trigger foods. There's also environmental considerations that may help with mitigating nausea and vomiting, such as the temperature of the room, the airflow, and exposure to noxious sights or smells. Every person that experiences nausea and vomiting will find some, all, or maybe none of these helpful, but they are worth trying because most of them have a minimal cost and are easy to try.
Okay, now I'm going to go over the pharmacological treatment for nausea and vomiting. And as we go, after you've finished your assessment, we've talked about the etiology of nausea and vomiting and the lock and key system, which refers to the neurotransmitters and the receptors, as well as the emetic pathway. Then you're going to understand why all that is important to put together in your history and your note-taking to recommend if you're a nurse for your scope of practice, or a physician or a nurse practitioner who can prescribe the proper pharmacological treatment. So it's important to choose the appropriate antiemetic based on the site through which the nausea and vomiting is most likely being mediated. You should choose the appropriate route of administration, consider the dosing schedule for your patient, and when possible, use only one antiemetic at a time and titrate to the maximum dose before considering switching or combining medications. So first we'll review prokinetic agents. These agents increase peristalsis, stimulate the cholinergic system in the gut wall. They block 5-HT3 receptors and activate 5-HT4 receptors, and blocking the dopaminergic pathway that slows gastric emptying. These agents are useful for the prevention of nausea and vomiting caused by chemotherapy, radiation, gastric reflux, and altered gastric emptying and peristalsis. They should not be used in patients who have complete bowel obstruction, GI hemorrhage, perforation, or immediately following surgery. These agents should be used with precaution in Parkinson's disease, high blood pressure, renal liver impairment, heart failure, and diabetes. Dopamine antagonists block D2 receptors in the chemoreceptor trigger zone, in addition to histaminic, muscarinic, serotonergic, or alpha adrenergic receptors by increasing gastric motility and encourages gastric emptying. These agents are useful for complete bowel obstructions, opioid-induced nausea, chemotherapy, radiotherapy-induced nausea. These antagonists should not be used in elderly or demented patients, or patients who have Parkinson's disease. Use with precaution in neutropenia, glaucoma, prostate hypertrophy, QT, interval prolongation, and extrapyramidal side effects. Antihistamines block H1 receptors in the vomiting center of the medulla, vestibular nucleus, and chemoreceptor trigger zone, and have antimuscarinic activity. They are useful for motion-related nausea or as a second-line agent for nausea related to brain involvement, which means vestibular disorders and increased intracranial pressure and bowel obstruction. They should not be used in elderly patients. They should not be used in conjunction with codeine, tramadol, tamoxifen, or patients that have seizures, epilepsy, and dementia. Precautions should be used with patients who have narrow angle glaucoma, prostatic hyperplasia, cardiovascular disease, hypertension, respiratory compromise, impaired hepatic function, and epilepsy. Serotonin 5-HT3 receptor antagonists block peripheral and central serotonin receptors, including those on the vagus nerve and chemoreceptor trigger zone. They're useful in both the prevention and treatment of chemotherapy and radiotherapy associated nausea or refractory nausea. They should not be used with drugs that prolong the QT interval or in severe hepatic impairment or in conjunction with tramadol. The precautions for these receptor antagonists is that they may cause constipation. Anticholinergics relax smooth muscle and reduce GI secretions by blocking muscarinic receptors. They're useful in terminal bowel obstructions, motion-induced nausea, and vestibular causes. They should not be used in the elderly and used with precaution in hepatic and renal impairment. Corticosteroids. The precise mechanism and method of action is unknown, but it's thought that they act centrally and may reduce nausea and vomiting due to an anti-inflammatory effect. Useful in nausea related to increased intracranial pressure, malignant bowel obstruction, and chemotherapy and radiotherapy induced nausea. They should not be used in long-term palliative chemotherapy due to the risk of masking sepsis or fever. Used with precaution in patients who have diabetes, dementia, or a psychiatric history and perioperatively. Cannabinoids. These agents act on the receptors in the brain to suppress nausea and vomiting pathways. They're useful for nausea and vomiting associated with chemotherapy and radiotherapy and should not be used in the elderly. Precautions are concurrent use with psychoactive drugs, sedatives, or any ethanol. Benzodiazepines enhance the effect of the neurotransmitter GABA. Useful for chemotherapy-induced vomiting and refractory anticipatory vomiting. Should not be used as an antiemetic unless as an adjuvant, and precaution is again in elderly patients. Octreotide reduces secretion of fluids by the intestine and pancreas, reduces GI motility, and causes vasoconstriction. Useful for malignant bowel obstruction, especially with high output vomiting that is unresponsive to other measures. Precautions include patients with diabetes, other endocrinopathies, elderly, and renal and hepatic impairment. It's hard to read all these after you've done so many. Okay, next slide, Laura. So this is just a graph. Just to let you know, we will archive the presentation so that you can go back and have a look at these and have the information. So here you can see how antiemetics and the receptors work with the centers that we talked about in the emetic pathways. I'm not going to go through all of it, but you can see how it puts together all of the pieces that we've been going over so far today, including assessment, your emetic pathway, and the etiology of nausea and vomiting. And when you decide which area is affected, then you can choose the proper antiemetic. Laura and I have gone through the presentation and listed the common antiemetic doses to the drugs that were in the graph and the previous agents. And again, we won't go through all of this, but you can definitely find the information either here or these are the drugs that are also listed in the Ontario Cancer Care algorithm for your mild, moderate, and severe nausea.
So you can see there's a variety of different medications in each drug class to allow you different ones to try depending on how your patient is presenting. and obviously check with pharmacy to ensure that there's no interactions between the drug that you want to try and any other medications or over-the-counter medications that your patients might be using.
So I am going to present first part of the case study, and Laura will present the second. I just have to say, Laura, that's very interesting watching ourselves on video from so long ago. That's why I
It's a little surreal.
Yeah, because I have a hard time pronouncing. That's too funny. Okay, so we'll now work through the case study to see if we can work through the Cancer Care Ontario algorithm in the assessment and management of nausea and vomiting. So I'm going to read this slide through and then ask a few questions. And if we could make this interactive and have people jump in with some answers to the question, that would be great. So Mr. T is a 67-year-old male patient diagnosed with lung cancer with metastatic disease to the liver. He is not currently undergoing any chemotherapy or radiation treatments. Upon assessment, Mr. T has increased abdominal distension and ascites. He reports that over the past week, he has become increasingly nauseated. His appetite has been decreasing, and in the past 2 days, he has had 2 to 3 episodes of vomiting each day. He is now complaining about increased fatigue and states the nausea and fatigue are impacting his ability to live his life. He is upset because the nausea and vomiting take away from the enjoyment he gets from eating his favorite foods. He has not gotten out of bed in 2 days. What other information would you require before consulting with his physician about managing the nausea and vomiting? So I'm looking here to the participants to jump in and based on your knowledge and, oh, here's one. One says
Chat says last bowel movement.
Yeah, and was there one before that, Laura?
It was the same answer.
Oh,
Two
okay.
people have said their first question would be about his last bowel movement.
Okay, and what other questions would we be asking? What other information? Or what other tools or pieces of assessment will we do? Current medication?
Somebody says, yep.
Yeah. So when does he vomit, for example, after meals? So a history of the vomiting.
Yeah, it's important to know if it's after he eats, before he eats, both.
Mm-hmm.
Somebody says, how much emesis and what color is it?
Okay, is there anything else? Any other answers? So Amanda will post with the video the resources, but one thing that we would really like you to learn to use is the Cancer Care Ontario algorithm that will lay this and the answers out exactly. So we'll give you that resource, and we had some great answers there. So we're gonna, if we were using the algorithm, then we would also use some other tools mentioned in the algorithm. So we would do a current PPS and assess what his usual functional status was compared to his status in how he's presenting in the case study. We would ask about what his current goals of care are so that we can discuss how we might manage his symptoms based on those current goals of care. We mentioned the bowel regimen, the last bowel movement, and the usual patterns of his bowel movements. Are there any provoking or palliating factors that are contributing to his nausea and vomiting? And were there any treatment changes or someone did mention medications? Were there any changes in medications, etc.? And the other thing that we might look at is, are there any worsening metastases that are actually having an impact on his nausea and vomiting? I think I covered that. Is there anything else you can think of, Laura, that?
No, I think that's a pretty wholesome assessment to make sure we've got all the information we need.
Mhm. Okay, we'll go to the next slide then. So here's some additional information. Mr. T was previously prescribed routine lactulose to prevent constipation caused by his opioids, but he stopped taking it 1 week ago due to an incidence of diarrhea. His last bowel movement was 4 days ago, and he's now passing gas. Mr. T informs you that the nausea worsens when he attempts to eat or drink more than a few mouthfuls. The vomiting occurred within 30 minutes of attempting to eat more than that. He complains about feeling full all the time, even when he hasn't eaten. There have not been any recent changes in any of Mr. T's medications in the past 4 weeks, and he reports taking all medications as prescribed. At your last
Except for
visit,
the lactulose.
right. At your last visit with Mr. T 2 weeks ago, his PPS score was 50%. He had recently completed a DNR and has told you in the past that he wants to stay home and deal with things here until it's time to go to hospice. His spouse supports his decision, but is concerned about his declining status.
So all the things we need to know. Okay, so let's think about how we're going to manage his nausea and vomiting. What are we going to do in regards to bowel management? What is the first thing we should do in case we are suspecting that his constipation is contributing to the nausea and vomiting? Go ahead and unmute yourself or pop it in the chat, whatever you're most comfortable with. Tracy says mush, push, whoosh. I like that phrase. We want those bowels moving. We want them soft, easy to pass, and regular. Kathy says, try a different laxative, but also inquire if the lactulose is ordered because of the liver mets. Exactly. Louise says, inform the doctor. Yeah. So we need to have a conversation both with Mr. T and his prescribing physician about why the laxatives are ordered as they are and whether we can tweak the process or tweak the regime to get him to be more on board with taking them on a regular basis. Huge, huge need to educate about the need for routine laxatives while taking opioids. So many patients are hesitant because they just do not know that constipation will not resolve itself on its own when they're taking opioids. What else do we need to think about before we start talking about antiemetic medications? Do you think it would be appropriate to have him go for scans of any type? Ooh, good one, Tracy. Consider the risk of obstruction. If he hasn't had a recent scan, we don't know whether those metastases have spread and whether there could be a terminal obstruction or a mechanical obstruction from the constipation. You're right. So we need to keep that in mind. We know he's passing gas, but he could be on the road to an obstruction. And you're right, the constipation could be related with the diarrhea. You can often get that overflow of liquid stool around the constipated stool when there's nowhere else for it to go. That's right. So what antiemetic medications do you think would be appropriate for him to be prescribed at this point? either by class or by drug name, whatever you're most comfortable with. And would you give it routinely or have him take it as needed only? If no obstruction, metoclopramide, preferably TID before meals. Yep. Could even do one more dose before bed if needed. What other medications do you think might be effective? Yeah, you're right, Tracy. Something like PEG for his constipation might be the most appropriate thing. Get him cleaned out, get him moving, and then scale it back. Something like olanzapine or domperidone or ondansetron might be appropriate also to try, just because of the way they also work on gut motility and peristalsis. Any other medications that might be appropriate to help at this point? What if there's a partial obstruction? What else might we see added? Yeah, octiotride, that's right. And if he had additional mets to the GI tract, what's another thing that we could try to help with the nausea? Dex. Good call, Louise. Yep, a corticosteroid, typically dexamethasone. What other measures might help, whether they're interventions, medications, non-pharmacological interventions for the nausea or vomiting? What else would you suggest that he try, or that would you expect the doctor to order? Yeah, it wouldn't be unreasonable to talk about a paracentesis to manage that ascites and see if that assists with the nausea and vomiting for sure. We all know how uncomfortable our clients can get when they have significant ascites and it's causing pressure on the GI tract. And as long, I suspect, based on what we've said, his goals of care are, staying at home as long as possible. If he's able to go have a paracentesis and come home and not be hospitalized for that procedure or for too long afterwards, that might be something that he's willing to try for sure. What non-pharmacological measures could we suggest that might be helpful while we're trialing some different medications and maybe waiting for a paracentesis to happen? Would, the good old home remedy of ginger ale or ginger candies be appropriate? Maybe. If he finds it's helpful, why not? What else could he try? Making sure he's sitting up after meals, for sure, that's a big one, especially when there's ascites. Keeping odors to a minimum when people are cooking, yep, that's also a big one. Quiet, relaxing environment, yep. There's nothing worse than being stressed out while worrying about whether what you're eating and drinking is going to make you nauseous or throw up. I think given the fact that he complains about feeling full all the time, I would suggest small amounts more frequently instead of 3 big meals a day. Definitely increase fluids, especially to help with the constipation too. and a cool, well-ventilated room would help. Yeah, those are all good things that seem to help people when they're feeling nauseous. Okay. Ah, yes, good, Kathy. If he's able to mobilize, that movement might help also. So we do all of these wonderful things, and a week later, you go back to see him. He's happily returned to his baseline and informs you that he is able to enjoy his favorite foods again, which means his quality of life has improved. He reports no further vomiting over the last week and states that he's only felt nauseated once or twice when he eats too quickly, but it passes and does not require any additional doses of medication. When leaving your visit, he says to you, "I pity the fool. I pity the fool who doesn't deal with their nausea and vomiting." And if you're under the age of 40, I'm sorry you don't get that reference to Mr. T. Does anybody have any other thoughts about the case study before we wrap up? Is there anything else you would want to know or would need to know or would want to try to help Mr. T with his nausea and vomiting? I think we've hit on pretty much all of them, haven't we, Linda?
I think now that I watched that in review, Laura, that it's pretty, we had a lot of information in there,
Yeah.
pretty full.
So there's just some of our references. We want to say thank you for attending our session. And if you have any questions, we'll take them now. You're welcome, Louise. It's always good to review these things on a regular basis.
And we did put some of the resources into the chat there, so feel free to grab those links. We will also send those out when we send out the recording as well.
Thanks, Amanda.
Thank you, ladies.
Thank you,
That was
everyone.
great.
Thank you.
Thank you.
Be sure to register for the next one coming up in June, I believe. And the
Yes.
information is on the website, and we look forward to seeing you all again soon.
Thank you again, everyone.